So thank you very much for the invitation to the organizers, for the kind invitation. I'm happy to really be here today. So I'm actually not going to talk about the tumor microenvironment. I decided to change a bit the topic of the title because we have some interesting CAR T cell data that I want you to see. Yeah.
No, this is your presentation.
Yeah.
Not the one you sent us today.
Okay. Why? Why not?
It didn't work.
It didn't work. Okay. Why you didn't tell me before? No?
Do you have it on your computer?
I do have it in my computer. Yes. Okay.
Yes.
Okay, that would be great. Yes, I would prefer if possible. Yes, thank you very much.
Sorry about that.
No, that's okay.
Okay, so we switch to the other computer, and meanwhile, I would say we go on then with a flash talk.
Yes.
So you have a little time to set up.
Okay, great. Thank you. Sorry.
Or would it be fast? Or you would like to...
Oh.
Okay.
Sorry about that. Just my... Okay, yes, sure. My disclosures. Okay, so I didn't have to explain here what's going on when we have an immune response, but basically this is just to show that after naive T cells have encountered antigen, they develop into effector cells, and once the antigen is gone, they're not needed anymore, so they must be eliminated, and but they develop into long-lived memory cells. The importance to have these long-lived memory cells is because we want to have a faster and more potent immune response. So this is to introduce the concept of memory heterogeneity. So we have a large number of subsets that we can identify. So this is put in a model where we have progressive differentiation from less differentiated memory cells into more differentiated memory cells. Here you have also different antigens that we can use, for example, by I-dimensional flow to identify them. The important point here is that they also have a precursor-progeny relationship. So the less differentiated can generate the more differentiated, but generally you don't have the opposite. The other important thing is that once when these cells differentiate, they tend to lose some functions while they acquire others. So, for example, we have shown a long time ago with Luca Gattinoni at the NIH that stem-like memory cells are at the very beginning of this process of differentiation. They have very potent proliferative capacity and stemness, but they lose these capacities when they differentiate and they acquire cytotoxicity, and they also become senescent over time. And this was an experiment that we have done at the time to demonstrate that the stem-like memory population is actually more potent than others. So if we transduce them with a chimeric antigen receptor, in this case, anti-mesothelin CAR, and put them in xenogenase mice having this human mesothelioma, we have a much better immune response, anti-tumor immune response, than the conventional central memory cells and the effector memory cells. And after that, a large number of groups actually looked into the characteristics of the T cell compartment in the T cell products of adoptive cell transfer. This is just a selection of the studies, basically showing that if you have a higher abundance of these stem-like memory cells in the products, you tend to have a much higher probability to induce complete remission in the patients. Instead, if the product is enriched with senescent cells or highly differentiated memory cells, so you don't really have that. So obviously, we know when we're treating tumors, we have a huge issue that many people today talked about, which is obviously exhaustion. So where do we place exhaustion in the differentiation program? So obviously, exhaustion, we know that it's characterized by the high expression of inhibitory receptors, lower proliferative capacity, lower capacity to produce effector cytokines. Initially, we thought that exhausted cells developed from highly stimulated effector cells chronically after chronic stimulation, but there's nothing more wrong than that, apparently. Exhausted cells develop from early differentiated precursors, which have the plastic capacity to generate also that state. This is something that John Wary and many other people over the years have shown. If you take effector cells, for example, during an acute immune response and transfer them into chronically infected mice, the effector cells won't persist. But if you take the memory precursors, those will be able to persist and generate exhausted cells. This is a report from us that we have shown a few years ago that you can find these stem-like exhausted cells. Seems contradictory, but that's what happens also in solid tumors. This is a fax of a non-small cell lung cancer tumor where we have the PD-1 positive compartment, and we were able to see heterogeneity also in that case. And in particular, there's a small population of cells that expresses, in this case, CXCR5, has PD-1, but doesn't have TIM3. So there's a presence of some inhibitory receptors, but not all inhibitory receptors. And basically, these cells are less differentiated than those that also express TIM3, are capable to self-renew and at the same time produce multiple cytokines. And we looked also at the time single-cell RNA sequencing data. And the bottom line here is that we have coexistence of multiple transcriptional programs in these cells, basically not just the expression of the inhibitory receptors, but also the expression of memory genes and effector genes, all of them at the same time in the same cell. And this is not true just for tumors, because if we look in healthy donors, we can also find early differentiated memory cells that express inhibitory receptors. So this is, again, flow cytometry analysis. In the CCR7 positive compartment, you can see actually quite a big proportion of cells that might express PD-1 and TIGIT at the same time. And in collaboration with Monica Casucci at the time, we have also shown that if we use these cells, these precursors expressing these inhibitory receptors in a CAR model, they work less functional. They're less functional than the inhibitor receptor negative counterpart. So over the years, there have been multiple ways to try to inhibit exhaustion or prevent exhaustion or somehow induce the stemness in T-cell products. One of the systems is something I mentioned before. So if you use N-acetylcysteine, an antioxidant, you uncouple differentiation from proliferation. So the naive cells are activated, they proliferate, but they don't differentiate that much, as you can see here from this CD45 rose CCR7 analysis. And again, once transduced with a chimeric antigen receptor in the classical NALM6 leukemia model, they do better. And recently, this is something that was completely unexpected to us. We have also seen that by metabolically reprogramming the T-cell product by using sodium chloride, we can actually induce this coexistence of stem genes and memory genes and effector genes at the same time in the same population. This is bulk RNA-seq of the cells cultured with supraphysiological levels of sodium chloride, and basically you see those genes highlighted in red are effector genes such as TBX21 or PRDM1, but at the same time memory genes in the same population. And again, this is translated into better tumor control when we transfer them into a solid tumor model of melanoma. So what was the mechanism in this case? It was not just the gene expression, but at the same time chromatin remodeling, because if you're looking at ATAC-seq profiles, we see that basically the sodium chloride induces opening of many genes related to effector functions like interferon gamma and granzyme B, and this is completely prevented if you remove glutamine from the environment, because sodium chloride is basically helping the cells to pump glutamine from the outside to the inside. But for some what reason that we still don't understand, the memory genes are untouched, so they don't care. So their chromatin accessibility is still open. These cells are capable to re-express these memory genes. In this case, we looked at LEF1, which is important for persistence, and CCR7. So it looks like there's this like chromatin open, broad chromatin opening for multiple effector genes and memory genes at the same time. So just to summarize this part in terms of differentiation, we have at least two trajectories of memory differentiation. One that goes down the exhausted path or dysfunctional path, if you prefer, and the other one that goes down to the functional path. So they're basically cells in these two different valleys. And obviously, when we have chronic stimulation, the cells tend to go down the exhausted path. And but there's now multiple ways to try to overcome this progress by using multiple different ways. I mentioned a few, but there's also genetic engineering of the cell products and try to have more functional phenotypes and memory function and effective functions at the same time. So now I want to share some data, published data that we have done together with Luca Gattinoni and Jim Kochendorfer. Luca is now in Germany, Jim's still at the NIH. And this is a donor-derived CD19 CAR stem cell memory trials for B-cell malignancies in this case. This was a phase 1, so dose escalation. And so the trial was done in this way. That basically, the trial involved the product that was developed at the NCI, which is now licensed for commercialization, and involved the retroviral transduction of the PBMCs from an allogeneic donor. We'll give you more details in a second. And the cells are activated with anti-CD3 plus IL-2, and they're given back to the patients, and this involved 20 patients. So this didn't involve 2 arms, but it was basically an amendment of the original protocol where the patients were asked to basically receive leukapheresis from the donor of the allogeneic transplant, where the leukapheresis was subjected to naive CD8 T cell isolation by magnetic separation. These naive cells were activated with CD328 beads plus IL-7, IL-21, and TWS119, which is a GSK3 beta inhibitor that we tested already 15 years ago. And this GSK3 beta inhibitor basically stabilizes beta-catenin, which then goes to the nucleus and helps to transcribe LEF1 and TCF7, which are important for persistence. And so this was just a purified CD8 T cell product, no CD4 transduced, but obviously the patient had an endogenous CD4 response, which I will discuss in a second. And this part involved 11 patients. So just to give a bit more detail, this was a dose escalation trial, but obviously in the case of the TSCM part, we had a lower dose being given because we also wanted to test if actually a lower amount of cells was more effective than the classical standard. I'll show you in a second. It involved relapse-remitting patients with relapse-remitting B-cell malignancies. These patients were treated with allo HSCT from unrelated donor or from a family donor. And again, 20 patients received the standard, and 11, sorry, there's a mistake here. The 11 received the TSCMs. And this is analysis of the product. So as you can see by high-dimensional flow, we can see that the products are completely different. So in the case of the standard, you have a prevalence of effector memory cells and terminal effector cells, and instead the TSCM product is about 80% pure if we use the standard strategy of gating, which is based on the antigens that are shown here. So as I mentioned before, the number of infused cells is different between the two groups of patients. So in general, we have about a median of 300 million cells given in total for the standard, and about 6 or 7 less times numbers in the case of the TSCM. So if we're looking at the full dose range, there's not very much of a difference in terms of the clinical outcome of these patients. So pretty much the same number goes into complete remission, partial response, stable or progressive disease. But actually, if we focus just on those that receive less than 300 million cells, so below the median, you actually see, and we have comparable numbers in that case, you actually see that when the patients receive this purified TSCM population, they have a much higher probability to undergo complete remission. It doesn't translate into a better event-free survival in terms of percentage, but we must acknowledge also that this is a small group of patients, so it must be tested in larger cohorts. In terms of CAR expansion, this is PCR of the CAR, so and then we count the number of cells per microliter. So you can see here the more or less dynamics is the same in terms of expansion, but obviously the patients receiving the TSCM, so the CARs in that case, they expand a bit slower. But still, if you look at the numbers, you have 1 log more in terms of number of cells per microliter, so suggesting that this population is actually highly functional in terms of proliferation. So we did a lot of immunomonitoring in this trial. This involved, again, 31 patients. We have about 8 time points per individual. So two groups, endogenous CD8 and CAR-T, and we did high-dimensional flow. This was done already a few years ago. So at the time we had only 25 color capabilities, but nevertheless, with flow we were able to analyze millions of cells. So you can imagine the number of events that comes up from this trial, and obviously the analysis here was capable just by using a massive use of bioinformatics to mine these high-dimensional data. So this is just an idea of the number of clusters that we can obtain when we do cluster analysis of the data. This is the number of markers that you have in columns and the different clusters that you can obtain in the lines. So quite a bit of heterogeneity in the whole cohort of patients. But then we were able to debarcode and then see what was going on in patients receiving the standard populations or the TSCM populations. So we can order all of these subsets in sort of a pseudotimes. And so in this hue map, you see here that you have less differentiated cells in this part of the graph, starting from naive cells, progressing towards effector memory cells and proliferating cells, and then resting down into terminally differentiated populations. And it's actually better visible when we look at the markers. So when along differentiation, we have a tendency of these early differentiated markers to get lost through upregulation of activation and proliferation markers, and finally markers of terminal differentiation, and we all know like CD57, granzyme B, and TBAT. So in terms of dynamics, so when we look at the different time points after infusion, you can see here that the cells start already a bit different, not a huge difference, but still different, and then they progress in different ways. So when we look, for example, the peak of the immune response for the TSCMs is here at about 2 weeks following infusion. Instead, for the standard was already very quick, about 5 days, between 5 and 8 days. And you have already differences at 2 weeks where the standard tend to progress towards terminal differentiation. Instead, when we look at the memory time point, we have somehow de-differentiation of the effector population that we see in the very beginning if the patients receive the TSCM. And this is better visible when we plot all of these clusters into a principal component analysis. So this is the trajectory of the patients receiving the standard, which follow this very simple differentiation process. And when we look at the TSCM is completely different because they start off very differently. They tend to progress towards more or less the same place, but then they end up in a different area of the graph. So if we look at specific populations by looking at the single markers, in the case of the standard, we have again highly differentiated terminal cells, like effector memory cells or terminally differentiated cells. But we have the reappearance of cells looking like naive or stem-like in patients receiving a TSCM, and this is associated with the expression of higher expression of memory markers such as IL-7 receptor and no expression of CD57. So they tend to go back to their original state and maintain their functional phenotype. So in conclusion, I think it's important here to show that we have possibility to induce patient in complete remission when we infuse CD8 T cells only in the absence of CD4, or at least CAR transduced CD4s. Obviously, the patient has the matched CD4 population, so there might be some endogenous immunity being activated. We don't know. It's something that we're looking into. There's a different trajectory of differentiation of these purified stem-like population compared to the standard product. So depending on where you start from, you're going to have a different scenario in vivo. And we have already talked about the independence from the CD4 positive T cell response. So this is my group. I want to acknowledge especially Alberto Suzano, who did a lot of in terms of profiling, and obviously Luca and Jim for the collaboration, the funding agencies. And again, sorry for the problem in the very beginning, and thanks a lot for your attention. I'm happy to take questions.
Thank you very much for these exciting insights. Are there questions? So I would start actually. So it's a very nice effect, right, which you see with your purified T cells then transfused to CAR T cells. So do you think this is a specific effect in the setting here of CD19 CARs, or is this then transferable also to other settings?
Yeah, no, so there have been a lot of studies with multiple T cell products. And including the TILs, so adoptive transfer TILs for melanoma. So in general, if you have a younger T cell product, they tend to have a much better response in vivo. So I believe it's highly transferable to other
and settings. I can go on with the second question. So you also mentioned reduced toxicity. So do you have more insights on this? If this is specified to specific toxicities, or is this in general lower CRS, ICANS, ICAD, and so on? Yeah, so I didn't have time to get into that, but just to mention a biomarker, a parameter of toxicity. So we have a strong upregulation of CRP in the plasma when the patients receive the standard product, which doesn't happen with the TSM. So, and that was associated with less grade 3 and 4 CRS. Yeah. Yes, please. Yeah.
Curiosity. So, what do you know about the long-term persistence of this type of population? Because recently, it's been shown that long persistent CAR T cells after 10 years tend to have a sort of strange phenotype, or they are completely CD4, or they downregulate CD4 and CD8. So what you can tell us about what do you see is the memory formation of CD8 distant memory compared to this long-term population? Yeah,
so not us directly, but this was done by Luca Biasco, I'm sure you know. So he looked at lentiviral insertion sites, and there's these memory stem cell clones that are able to persist also long-term. It's a bit difficult to do because it was difficult to purify these cells like many months after infusion, also because the background of the staining is actually quite high. But some of the clones that we see in the very beginning are capable to evolve long-term and persist long-term. That was done, unfortunately, only on 2 patients where we had enough material. Yeah.
Thank you very much for the talk.
Thank you.
Thank you for the insights. What is your take on the temporal changes from manufacturing until administration, injection to the patient, since it seems to be a dynamic product, the CAR-Ts? Is there anything you would advise to consider?
Well, so this one was designed years ago. So now there's much better protocols to generate, including rapid expansion or otherwise the protocols to generate 24-hour CAR-T in 24 hours from Mike Malone, for instance. So that's something that we should consider just to advance and accelerate as much as possible from the time of apheresis to infusion. Yeah. Yeah.
Any more questions? Okay.
Okay, thank you very much.
Thank you very much once again.